Great job, Sharmila. Um, has anyone talked to Sonia or Jess if they were going to join? If not, we'll just get started.
I can text them. I haven't heard
Cool.
anything.
All right. Thank you, Sharmila. All right, in the meantime, we'll get started. So today our first lecture is going to be Epic 101, mostly concentrating on billing, just some billing things we all wish we knew. Hopefully by now you kind of have started getting started and your feet wet and kind of exploring billing on your own, but hopefully we can all learn some tips based on this. By no means am I a billing expert. I think we had a billing meeting during one of our division meetings and it was wildly overwhelming and almost too much information. So I'm trying to keep this pretty simple and short. And of course, anybody, if they have tips or things that they do, please chime in for sure. Um, so the main things when you're billing, you need three kind of technical components. So I think we are all familiar from working in the clinics as well. You need your labs and your ordered. So anything you kind of want to tee up in terms of referrals, medications, images. And then the next step would be anything that you're trying to counsel on. So don't forget, if you're doing the work, you might as well bill for it. So if you're counseling on smoking cessation, if you're counseling on obesity, or if you're counseling on alcohol consumption, there's ways to bill for those things. You just have to make sure you put it in your orders, that you document it in your plan. And there's different dot phrases for that. And then you add what's called the 25 modifier, which we're going to go over. So that's your labs and your orders. And then we have our diagnosis codes. So obviously, what are you linking all your orders to? And then the last component is what's called the E&M code. So how are you going to bill this? What is the insurance company seeing this kind of coded as? And that's kind of our main focus today. So there are two types of ways to bill, medical decision making and time-based billing. So time-based billing is relatively new and was enforced in the 2021 billing year. It can be advantageous, and we'll go through ways of when to use time-based billing instead of medical decision making. But medical decision making is usually the most common, and you'll find that the MDM and time-based billing, they end up being about the same except in certain situations. So medical decision making, you're thinking about how complex the visit is, how many medications or refills are you doing? Did I speak to other providers? Am I speaking to family members? And did I do, pre-charting or post-charting that took up time for you as well? And then time-based billing is physically how much time. So this was advantageous for doctors because we do a lot of pre-charting and post-charting. The work doesn't stop just when we're in the office visit. So this was really helpful for including and recognizing that we're doing that type of work. So essentially, there's different time measurements of what we would link to billing. So, um, 20 to 25 minutes or 30 to 35 minutes or 40 to 45. So really good examples of when to use this is if you're counseling somebody on something that's low complexity, such as say anxiety or obesity. Well, maybe it's not low complexity, but it's like one problem, but you spend a lot of time doing it. So you might have someone who's really anxious or depressed and you spend 45 to an hour, counseling with them or sending them or setting them up with other providers or, for example, I sent somebody to the ER this morning for mental health. So that is a low complexity, but it took a lot of time. So whenever you're using time-based billing, you have to document that you use time-based billing. So you use the dot phrase that I put here at the bottom, dot ATT am time, and you fill in how many minutes. For billing, you don't want to use a range. So you don't want to say, I spent 40 to 45 minutes. They want an exact time. Um, Personally, I don't, look at all the minutes, but I estimate how much time I used. So, you might say 40 minutes or 42 minutes, something like that. Um, Anytime you're using the 25 modifier that we'll go over, it can't be included in your time, meaning if your MA spent 15 or 10 or 15 minutes doing an EKG, you can't include that in your time. Similarly, if you have a resident or a student seeing the patient first, you can't bill that as your time. So what I typically do is I just extrapolate how much time the resident spent with that patient and imagine like if that was me, how much time I would have spent. The last thing to be aware of if anybody is using the DAX dictation system, um, well, I'll back up. So if you're using time-based billing, it all has to be within the 24 hours of that day. Meaning if you pre-charted the night before for 15 minutes, you can't use that in your time-based billing. If you pre-charted 15 minutes before the patient came in the office and you seeing them, you can. So it has to be the same calendar day. So the reason I bring up the DAX dictation is sometimes, if you don't sign the note that the documentation specialist sends to you that day, you sign it the next day, you can't use time-based billing. So hopefully that makes sense. And if you don't use DAX, you'll figure it out when you start doing it. So this is the chart that when you start working, they show you, and it is wildly overwhelming. And honestly, I've tried to pick through it, but it's a lot of information. So teasing it out a little bit easier, this is essentially just a few examples. Hopefully you can see of when to use different complexities. So low complexity is a 99203 or 99213 based on if it's a new or established patient, which we'll go over, but that's your basic UTIs, URIs. They came in with a rash, they have high blood pressure, they're on one medication, and their blood pressure was excellent. Moderate complexity is the most common. So this is a 99204 or a 99214. So this is your most common one we're going to be using. So patient comes in with like 2 or 3 comorbidities, you're checking their medications, you're checking labs, or they have one chronic condition that's really uncontrolled. Typically, this is what you can use. In moderate complexity, you can also include if there was a like patient representative there if they come from like a group home or if they have a parent there or a child helping them. You also can include if you reached out to family members or other providers, and that only boosts your moderate complexity and documentation for that billing. You also can include in your diagnosis codes different social indeterminants, and that can help with moderate complexity, such as homelessness or financial insecurity or unemployment, something like that, which we recently went over in one of the division meetings. And then high complexity. This is rarely used, but you can either get this by billing based on time, or if you have a patient who you did spend a lot of time with, either going to the ER or you did a lot of extensive care coordination. But if you also have a really complex patient and you did a lot of pre-charting for them and going through records, don't forget if you did it the same day, you can use that for time-based billing and you might get up to 45 or 50 minutes, whatever it is.
Hey, can I ask
Uh,
a
yeah,
question?
of course.
If you go back to that slide, you wrote so under low complexity it says refills, but then under moderate it says medication. So is that only if you're doing new meds?
Yeah, so I don't know the exact. If we go to this chart, it's probably on it. But typically, my standard is if I'm just doing like a refill for a blood pressure med or anxiety, like Lexapro 10, and I didn't change anything and they're stable on it, and that's all I'm seeing them for, I'll do like a 99213. If it's, I'm refilling like 3 different types of medications for different chronic conditions and I like reviewed all of their stuff, then I would do a 99214. Or I adjusted and changed the medication. If you're going from Lexapro 10 to 20, and it was a short, simple, easy visit, I'd probably do a 99213. I don't know if Rachel or Navi or anyone has comments on how they do that.
When I met with the billing people in the beginning, I had like a lot of questions about that because when you really read, it's so variable with everyone's interpretation of the guidelines. So basically what they told me was that yes, like what Marlena said, if they're just coming in for anxiety and they're stable and you're refilling their Lexapro 10 and you don't do anything else, then, fine. But other things are like, then if you document that you're doing a second thing, like let's say you did some counseling, like counsel a patient on like stress management and coping mechanisms. Well, you're refilling the med and you're doing counseling. So then technically you're doing two things. So even though they're just there for anxiety, then that'd be like a 99214. Or if you said like following with therapy, like office note reviewed, like doing CBT or whatever. So that's like a second thing you're doing. So it's easy to kind of get up to that 99214 with documentation when you're probably already doing that. You just have to write it in the chart that you're doing it. So like with diabetes, if you're like A1C stable, discuss like lifestyle modifications of healthy diet and exercise, reviewed ASCVD, blah, 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 foot and eye exam up to date. Like if you kind of beef it up a little bit without actually changing any medicines, by document that you're probably already doing, then it's really easy to get to the 214. You just have to write it down.
Okay.
Yeah, I totally echo with Rachel. It's all about documenting because it's not like someone's coming in and you're like, okay, let's keep this medication. You're obviously asking them how they're doing and other, techniques like that. I probably very rarely use a 99213, but I do throw it in there every once in a while, especially if it's an easy sick visit or a stable chronic condition that you just so you're not overbilling all the time. And Rachel made a good point in the comments to not use a 99215 too often because that can also you be flagged for getting audited or anything. But again, if you document it and it's appropriate, it should be okay. Okay. So now we'll kind of dive more into the E&M code specifically. So something I just wanted to show you here is what I created in my Epic and what I learned when I first started. If you guys haven't done this already, when you go to your level of service, so if you open any of your patient's notes who you haven't seen yet and you click the wrench at the top here, you can customize all of this stuff. So essentially what happens is when I am going to bill, I don't have to think about like 99213, 1405, anything like that. I just click on these buttons and it automatically populates it into the level of service there. So we'll go over these, but you can see I organize it just by established care, and then new patients and the Medicare, the hospital follow-up, and telemed. And the slide before it just shows with the new update, they included this telehealth mode. So that's what my, level of service and E&M codes look like. Okay, so when you're seeing a new patient and you're learning how to bill, the way I kind of have taught my students and residents is it a new patient or is it an established patient? So here's the new patients, and the next slide, we'll go over established patients. So based on a new patient, who qualifies first as a new patient? Anyone who's new to Cooper, anyone who hasn't been seen in over 3 months, and it has to be beyond like the month they were seen. And then if the patient has seen another primary care doctor and is switching to you.
Sorry,
I think, Navi, you're going in and out a lot.
just to clarify, who hasn't seen in 3 months.
Say it again. Sorry, you went out.
Sure. I was just saying it's for a patient who hasn't been seen in 3 years, correct?
For some reason, the audio, I don't know if you want to type it in the chat. You're probably correct of whatever you're saying, and it's something with the month and the year. Oh, yeah. So 3 years, not 3 months. So they haven't been seen in 3 years. And then when I say to the month, I mean like if it was like November 2018, it has to be at least, it can't be like you can't see them in September 2021 and say, oh, it's been 3 years. It has to be to the month, is my understanding. Additionally, if they saw, Rachel as a patient and then they come in and see me, 6 months or a year later, I can't bill it as a new patient. So a lot of you guys, like I took over first, like Dr. Kirby and Dr. Sherman patients. I couldn't bill them as new patients if they had seen Dr. Kirby and Sherman within 3 months. The catch is sometimes I get a family med patient who comes to me, and I never got a straight answer on this, but I bill them as a new patient because it's a different department. I see Rachel saying yes. And I haven't gotten a kickback yet.
Yeah, when I asked, because so for all the new people, someone from billing, I don't know if Marlena, they did this with COVID for you, will like come out to the office like after a few months and like pull some notes, which basically like had incorrect things to kind of show you where you billed wrong. And they told me that if a patient's a new patient from Cooper Peds or a new patient from Cooper Family Med, since it's a change of department, they can come in as a new patient to you because it's a switch.
Excellent. So that starts as a new patient. So then the question you always say versus new versus established, are they a well visit or are they like a sick visit? And when I say sick visit, I'll explain what I mean by quotes. So if it's a well patient and they're new and they're just coming in to establish care, they've had a primary care doc before, they just want to say what's up and have some maybe medication refills, you're not doing a lot of complex stuff, then you break it down by age. So if they're less than 39 years old, it's a 99385. And if they're older than 40, it's a 99386. That being said, I just click on these buttons too. I don't have them memorized.
The only
Okay,
thing
so
with
now if
that
you
is
have a
if
new
they're,
patient,
oh,
yeah,
sorry. The only thing with that is if they're a
no,
Medicare patient, they cannot be a new patient and a Medicare wellness exam on the same visit. So if they're a Medicare patient, they're trying to come in for a wellness, you have to tell them they have to come back for their Medicare wellness exam because Medicare won't acknowledge like new and wellness as one visit.
so can you bill them as a greater than 40-year-old patient, like a 99386? Oh, so it has to be
No.
like a 99204 or 5.
Yeah, it has to be like an acute visit or like a 0304, and then they have to come back for the
For a
initial
wellness.
subsequent whatever it may be. Yeah.
Which most people are amenable to. They're like, if you're like, I want to see you in a month, they're like, oh, really? Excellent. So then going to a sick visit, these are patients who come in, they're looking for a new doctor, maybe they haven't seen someone in a few years, or they're switching providers, or they have a new rash they want you to look at, or they have uncontrolled hypertension. So now you're doing a little bit more work. So same thing as we talked about before, you think about low, moderate, and high complexity. And that's where you're doing a 99203, 04, or 05 and clicking off which one. So similarly, you take this, and if it's an established patient, you say, okay, is this a well visit or like a sick visit where I'm going to do stuff? Starting with a well visit, same thing. Are they less than 39 years old? Are they greater than 40 years old? And then based on if they're older than 65, if they're not on Medicare, which not all greater than 65-year-old patients are, it's a 99397. If they are on Medicare, there's no such thing as like a physical for a Medicare patient. So you have to do a Medicare well visit once a year as their physical. The tricky part is a lot of your Medicare patients are your older patients who you're probably seeing every, say, 4 months or 6 months. And that's where, you know, they might just be stable in their chronic conditions, but you're seeing them. You still can't bill it as a well visit. And we'll get to the Medicare well visits. So just moving over to the other side, sick visits. So this is like probably the most that you'll see. Like we said, the 99213, 1415. These are the patients are coming in, they have complaints, they're sick, they're not feeling well, they have 1 or 3 issues. Or it's those patients I just talked about who come in every 4 or 6 months and you're managing their diabetes, their high blood pressure, you're doing health maintenance stuff for them and you don't want to bill the well visit. This is when you use the 99213, 1415. And then also what it reaches also you could bill only for Medicare while they have Part B. So Rachel, do you mind talking about this slide? So I put in a few things here about the Medicare well visits, and they are a little confusing because there's 3 different times, but of course you can always refer to this, and Rachel knows a lot more about the Medicare stuff than I do.
So I'm definitely not an expert, but
Yeah.
I'm doing a QI project. So I've kind of emailed Dan Hyman like a laundry list of my Medicare questions for the annual wellness exam. So I think the first important thing is that like so many Medicare patients will get booked as like new patient physical, so can't do any ACO visits as a physical. The other thing that's important to know is at 65, everyone automatically gets enrolled in Medicare Part A. But if they're still working, or some people get like retirement insurance benefits, they don't buy Part B. So if you don't have Medicare Part B, you're not eligible for a Medicare wellness exam. So like when you look on the left-hand side to see what type of insurance patients have, it may say primary insurance, like Independence Blue Cross, secondary insurance, Medicare. So if the secondary is Medicare, that's most likely means they just have Part A, which you would just do a regular physical because their primary insurance picks that up. So Medicare Part A doesn't really do much. Medicare Part B is like the part that does, any like health maintenance, lab work, X, Y, and Z. Sometimes I can't tell from Epic, so I'll just ask my front desk staff and they'll be able to tell me like what insurance they're using as the primary. Also, the new updates on Epic, it's a lot easier because most of the time, I'd say like 98% of the time, that health maintenance thing gets it right, where it will actually say if you need the ACO wellness exam. The other thing is the call center gets like mixed up a lot, and they'll put annual well visit, even if a patient's over 65, even if they don't have Part B. So just be mindful of that because they don't really pay attention to the insurance. They'll just kind of book it based on their age. So when you have the initial Medicare well visit, it's at age 65. The important things for that is they get offered an EKG at that time. So you can't do an EKG at any other wellness exam because an EKG is not considered like a wellness thing according to Medicare. And they also need to have an eye exam done. So what I usually do is if my nurse doesn't realize or my MA doesn't realize, I'll just have her do it like at the end of the appointment, the eye exam. And they have to document the eye exam in the under specialty in Epic in order for you to get credit for it. And then for all of them, you have to do the falls, review tobacco cessation. The first code has to be that Medicare Z code. That's really important. And then the other thing is family history. Unlike Marlene, I inherited like a lot of patients from other people that just had nothing in their family history, and it was just going to get reviewed. So, they have to have some family history. And then for anyone who can't tell you family history, there's actually a spot, like a checkbox that they put in Epic that says like unable to obtain or like, no relevant family history or whatever. So if they can't give you anything, you can actually just check that box off. So like, let's say they're like cognitively impaired or they have dementia or whatever and can't get a history from them. What are the other things? So the first is the IPPE at 65. So sometimes I'll get a patient that doesn't know when they went on Medicare and they're like 66 or 67. I don't know if they really had that initial visit or that IPPE. So when I asked Dan Hyman, he said that you should just bill the Medicare subsequent for that because that won't bounce back. But if you bill the IPPE and they already had it, then that code lady is going to email you and say they already did this. But if the patient turns, let's say 68 and they were on commercial insurance before and they just went on Medicare because they retired, it doesn't matter. You don't have to be 65. It just has to be your first visit. And then the initial Medicare visit would be the following year. So it's IPPE, initial, and then subsequent. The initial and the subsequent kind of do the same thing. They're not really much difference in terms of like requirements. It's just like the two different billing codes like Marlena has there. And then, you're going through the questions. Obviously, for the diabetics, you want to document the foot exam. That's really important in there.
I think the main thing to know too is, so it's every year to the month. So if it was like November 23rd of last year, you can do it in November of, the next year. It doesn't have to be to the date, but unfortunately your front desk staff can't physically, put in an appointment before it, but they can just do a 30-minute. And the big thing to know is it is a financial reimbursement. So Medicare gives money, and then if you get X amount of your patients ACO visits done by the end of the year, money goes into like a pot and you get some of that money or a good amount. And So the next slide, we'll just keep moving on here. The next slide, hopefully you guys have all seen the ACO visit. You just have to click it off. Technically, some offices have an LPN do it, but if the physician does it, you can bill higher. Okay, so let's talk about, well, what if the patient came in for their wellness visit and obviously they're going to talk about other things there. It's usually not just like a straight shot. So this is when we can start using what's called the 25 modifier, which we'll go over. So this is the example where the patient comes in and either you do the ACO visit and then you talk about, again, like their high blood pressure that's uncontrolled, or you talk about, worsening anxiety, depression, or insomnia they're having. You can technically bill for 2 visits with that, meaning you can choose one of the Medicare codes, so like say the subsequent visit, and you can add a 25 modifier on and add in one of the established patients that we talked about, so the 99213, 1415, with the understanding that your patient will get a copay. And some patients, understandably, aren't happy about this because they felt like this was their one free visit for the year. So just be conscious of that. I mean, if you're doing a lot of work or something really extensive beyond the basic, oh, I checked your blood pressure and your diabetes numbers, then you can consider adding on like a 99213 or 14. But this is when you see providers billing for 2 visits in one. This is kind of how it gets done. So now we will go on to the 25 modifier. So here, this is kind of my format I have. So I chose the subsequent visit for Medicare annual wellness visit. You click modifier and I have my 25 queued up here. And then you have to click this button if you're going to add another E&M code. So if you're doing a 25 modifier for a vaccine or an EKG, which we'll go over, you don't have to click it. But additional E&M codes, you'll click this and you'll type in 99213 or 14, whatever is appropriate. And then after you do that, you click on this red and blue circle and you'll get this chart over here on the right, and you'll kind of click off which ones pertain to the extra visit you did. So the one up at top, the preventative visit established, that's my normal physical. And then say, well, I talked, extensively about the hypertension and the chest pressure. That was my 99214 that I added. Okay, so the next thing to talk about is the hospital follow-up visit. So this is really good reimbursement purposes, but there are strict things that you need to complete and able to bill for it. So over on the left here, one of the most important things is after a patient of yours gets discharged, you want to ensure that there's a 48-hour transition phone call called after the discharge, and it has to be documented. So probably right now you guys aren't getting notifications, but hopefully in like 6 to 8 months, you start getting notified when your patients are discharged. You might get like an Excel sheet, or you might just get a notification in Epic. And that's how you'll know. And then the second component is you have to see the patient either within 7 days or 14 days based on which E&M code you're going to do. And you should use the hospital follow-up template. So up here you can see 7 days or 14 days. Obviously 7 days within discharge have higher reimbursement than 14 days. So the most important thing is if there's no call documented, you can't bill for it. So it's just frustrating if a patient comes in, you meet all that criteria and there wasn't a call documented. So what I did is I created a dot phrase, and whenever I get notified that a patient's discharged, I'll just use this dot phrase that I have in here, send it to my LPNs or MAs. They call and they create, the telephone encounter, or I'll create it for them. And then I know that it's already documented in there. Different offices have different protocols. Some offices, the LPN or MAs are monitoring the discharge list themselves, but I found that didn't really work for me. This is just that dot phrase you guys can go back through. So the next thing, I don't know if you guys have done, probably you've done a few hopefully by now, but telemedicine visits. So for telemedicine visits, you always want to use the telemedicine template that they already built for us. If for some reason you started a visit, it gets converted to telemedicine, or you just didn't realize when you were pre-charting, you can use the dot phrase dot telemedicine and that'll pull in that fancy header that says this is a telemedicine, it was audio or video, and go from there. This is just going back to this. Okay, so 25 modifier, try and speed it up a little bit because we're short on time. So the 25 modifier, this is when you're doing anything extra beyond what you were expected to do for the visit. So all of these vaccines listed here, if your MA gives it, if you do an EKG in the office, you do any type of this counseling, cerumen impaction, you do an incision and drainage of like an abscess or draining like a joint, you can include this. Just make sure you have the documentation in your plan, as well as using the 25 modifier. If your patient is coming in for tobacco cessation counseling or they're coming in for a drainage of a joint, you can't use a 25 modifier because that was not excessive of what the visit was supposed to be. So these are just kind of tips and tricks I just put together and that I do. If any of them help you, or if anybody, over the next few days or weeks realizes there's certain tips that they do, please share and we can add it to this PowerPoint. So just like I customized my E&M code, you can do the same thing for your diagnosis code. So when you're in the visit with a patient, I literally just go here and click like hyperlipidemia, hypertension are the most common ones. And if you go beyond this grid, you can click more, and that's where I have like vitamin D deficiency, screening for breast cancer and other options like that. Another good way to have shortcuts is if you don't use this already. I remember like Iris Hagen's always encouraged me to do it, but I never did. And now that I do it, I don't look back. So you can look at creating panels for yourself. So if I have a routine female or a routine male, you essentially group together blood work that you can order all at once. Same thing, titers is a great one to have. So I put this in here just so you can see some examples of ones that I have, or if you guys have suggestions of ones you have, it'd be great to add. So diabetes panel is helpful. Titers, like I said, for this time of year where people are doing pre-employment in school was really helpful. STI, and just things that I think I added one recently, like H. pylori, of things you don't want to keep looking up how to treat, and you just want to put it right all there together. So to make this, what you do is you go to any patient encounter, and like as if you're going to order it for the patient. So you would tee up like say these 3 things in your panel order. You press create panel, and it pops up over here and it would create this, and you just say what you want it to be named. So I named this one diabetes panel, and then you can make a preference list for it. And then when you go back, it'll pop up as a diabetes panel like this. So this is the example. I just did like an H. pylori quadruple therapy the other day after looking it up. So now when I click this and I click accept, it pulls up all those medications and the right doses for how to treat it. Same thing, I made a favorites for preventative. So I have like obesity counseling here, smoking counseling, DEXA, etc. You guys can go back and look at these. So entering Cologuard in the chart, if you guys haven't done this, essentially you order Cologuard and then your office should have a form to sign. And then, my office protocol is I already have some pre-signed forms, which makes it a lot easier. And I give them to my LPN and fax them out, and then the patient gets them to their house. The tricky part is you're going to get results in your Cologuard under media, that they're positive and negative, and you have to learn how to enter them in if you haven't already. So the way you do this, again, this is something to just come back to when you have that situation, is you go to the top left where Epic is and you create an encounter and you name it abstract, and you'll see something called results console. So you'll go down to Cologuard and you'll click this little test tube button. And when you click that, it'll give you a space to type in positive or negative, as well as a space to write the date in. And once you click close and you sign the visit, it'll pop up in like the results review, like here in the bottom left. If you haven't seen this button before, this is a great way to check the PMP within your Epic chart. Whenever you're under plan, you'll see PDMP review. So you click that and then mark and review as closed. So you don't have to go to the actual PDMP website. Again, a dot phrase is something that's great when you're refilling narcotics to just jot it down. This is my dot phrase on the bottom right to make things a little bit easier. So I had this happen a lot. Like I was taking over for those doctors, and the primary care doctor would be like a family med doctor, like I said, Sherman or Kirby. So what you do is if you click on that, you can click Add Me, and it'll change the primary care provider to you. So that's just a little trick. This is something I recommend under communications. So when you're writing a letter, to definitely favorite this schoolwork excuse letter because that's probably the one you'll use like 8 out of 10 times. Get a stamp if you don't have one. This will save your life for like forms. Just ask your manager or someone who's in charge for one of them. This is something I learned recently, Bayada, which you will sign a lot of forms from Bayada, home health, PT, stuff like that, has an online portal. The reason I like this is reduce the amount of forms I have to actually sign. And what you can do is you log onto the website with the login they give you. You can sign all your orders at once after typing in your password. So I just bookmark it on my favorites, and I had my office manager set this up for me, which is nice. I wish all of them did that. And those are my tips for now. If anybody, I think we're like a little short on time, but if anybody has any, please send them to the group. That being said, we are going to try and start using Slack, which I see some people entered into. I don't know, Rachel, if you want to just say like a 2-minute thing or a minute thing on how Slack works or what to do for it.
Yeah. So first and foremost, it's important to know with Slack is it's not like Tiger Text, so it's not confidential, it's not HIPAA protected, so everything should like be without patient identifiers and like no screenshots or anything from Epic. We want to like use this and have fun, not get in trouble for using it. So Slack basically is like a chat rooms. So if you already have a Slack account, then you actually have to go in and add a workplace to be added to the Cooper PCP's channel that Marlena created. So like if you're on your phone app and you just click on like the left, like pull the left side over, you can actually hit add workplace, and then that you can actually search for the Cooper PCP's group. If you have never made a Slack account before, I would just download the app on your phone first, then click on the, or your desktop, however you want to do it, and then click on the link Marlena sent out, and then that will allow you to actually get into like our workspace as like your primary place. And then basically you set up channels. So I think it came with some like standard channels. I just added like some other ones just to was playing around with it. So for example, like, you know, there's one that's like just for fun. Then
like
near
the dog
peer. So I
pics
thought
one.
the dog pics. Yeah, I stole that from my husband, from my husband's workspace. So like just for fun is like, you know, oh, like there's happy hour somewhere or whatever, just to like send it out to the group, or does anyone want to get together? It's going to be a nice weekend. I put one as like near peer, so like, you know, oh, what time, or like I'm running late or whatever, so you can send it on that Slack channel. And then like primary care knowledge, so like, you know, places that you have like questions, you know, whatever it may be. And so anyone can create any channel. I made them all private, so, you know, not or the ones that I made private so that people who just like search for primary care knowledge won't be able to like see our channel, because Slack is like an open marketplace essentially. So you can private message people, you can put things in the group chats, like you can set up your phone, you know, to get notifications to, you know, to your phone, or just not get notifications just when you click in. I mean, it's pretty straightforward. Cooper doesn't have like the more sophisticated one, so this is like the free one, which I think is plenty for us. But anyone who, like, you know, feel free to set up a channel with whatever you think is, you know, something that is important to you that we should talk about. And
I mean, even if we wanted to have channels like a diabetes channel or, you know,
exactly, yeah, I mean,
rheumatology, stuff like that could be great if we're actually
yeah.
starting to use it more.
Right, exactly. So it can get, I mean, obviously whatever level of, you know, intensity you want.
Great. And then the other things we're working on is dropbacks. I'm like a newbie, but I'm trying to set that up. So you can certainly, Dan, you can sit here. You can certainly use the channels for that. I mean, the Dropbox for that. I'm going to put the lecture PDF, like a one-page summary there, and then hopefully this PowerPoint I'll also put there. And we can also record these lectures, which we're doing, and the goal is to hopefully put them up on that YouTube channel. So if anyone wants to go back and watch it or couldn't make it, we'll do that. And that's our goals for now, and we'll see how it goes. I hope today was informational. Sorry I rushed through